Hello, this is NeuraSignal. This is your TCD with bubble presentation, and you are watching TCD with Tony. Today we're going to review the purpose of TCD bubble, TCD, PFO, performing TCD bubbles, the clinical evidence behind it, how to report this, and connect a purpose to finish. First, we'll start with what is TCD. TCD is transcranial Doppler. We use a 2 megahertz probe. It's a pulsed wave transducer. We will place it on the side of the head, the temporal window, so near the ear. So as you see here, this probe is placed on the left side of the skull. We will see two different screens. This is called M mode for motion mode, and this is your spectrogram. So what we'll do is we'll look at these two different screens. This is an overall view of many depths. We can see vessels coming towards the probe in red and vessels going away from the probe in blue. Coming towards the probe, the blood flow will be above the baseline, and going away from the probe, the waveform will be below the baseline. To show the comparison of depth range, we're going to start at the top of the screen is going to be correlating to the top of the skin surface. And as you go deeper into the brain, you're going deeper into the M mode. So here we have 30 millimeters, 40, 50, 60, 70, and 80. This M mode can go very deep, so we need to be aware at 75, 80, we are crossing to the other side of the head. So that shows just how many depth ranges this M mode will provide for us. So looping TCD in with bubble. When is a TCD bubble study needed? When patients present with a cryptogenic stroke, cryptogenic just means there's no known reason to why this patient had a stroke. There's no significant carotid artery disease found, basically less than 50% stenosis in those carotid arteries. No heart conditions, no atrial fibrillation, and then this actually is 33% of ischemic strokes. So the stroke is the third most common cause of death, leading cause of adult disability, and 795,000 strokes per year. Moving along, TCD bubble is commonly performed for right to left shunts. A right to left shunt is any connection between an artery and vein. One of the main connections between artery and vein is a patent foramen ovale. Fetuses have a normal opening between the left and right atria, the upper chambers of the heart, at birth. This opening is called a foramen ovale. If this opening fails to close naturally soon after the baby is born, that condition is called a PFO. With PFO, the underlying cause of stroke is the paradoxal embolism. 25% of the general population will have a PFO, so that is a high percent. Of these patients that present with cryptogenic stroke, 43% of them will have a PFO. The clinical evidence behind TCD bubble exams is well established. You can see here in our recent bubble study, 3 times the detection rate was found on TCD versus TTE. So the NovaGuide robotic system was used to detect these right to left shunts. So 3 times more patients were identified to having a PFO than were found on standard TTE exams. This led to 2.7 times the detection of intervenable shunts. These patients were able to have treatment for these PFOs to prevent recurrent stroke. That existing evidence is apparent here. You can see the use of TCD and PFO detection has a significant base of existing literature with nearly 3,000 references on Google Scholar. So here you can see TCD and TTE, the sensitivity, 96% is the sensitivity of TCD compared to 45% on a TTE. So this is clearly well-established method in detecting our PFO. Along with recent clinical trials, we have demonstrated that PFO closure significantly significantly reduces the rate of recurrent stroke. So this can change our guidelines significantly. We are leading a path to provide better patient care. Just to touch on the pathways of stroke in PFO patients, what happens is an embolization of a deep vein thrombosis, or a DVT, through a PFO is a potential pathway of stroke. Also, clot formation within the PFO tunnel itself is another cause of stroke and has been associated with atrial septal aneurysm. Just to walk through the pathway of stroke in PFO patients, so what is happening is we are putting an IV in the vein at the elbow, the antecubital fossa. What we're doing is agitating some saline, pushing that through. It is traveling through the vein into the right atrium, and it will cross over from the right atrium to the left atrium through a PFO if that PFO is there. And after it crosses over from the right to the left atrium, it will travel through the arteries up to the middle cerebral arteries at the base of the brain, and that is why we'll hear the bubbles there. So the TCD cannot determine between a PFO and an atrial septal defect, however. So when a PFO is present, the Valsalva session should always produce more bubbles than the resting injection session. The resting and Valsalva sessions can have the same number of bubbles when it is an atrial septal defect. How to diagnose PFO? PFOs are usually diagnosed with transthoracic echocardiograms. It's the most common method for PFO testing. 5.5 million complete echo studies performed in outpatient settings in 2018. There's pros and cons, of course. The pros are we can see the heart, we are seeing the structures. We can visualize confirmation of the cardiac shunt. The cons, however, are the low sensitivity. We saw the sensitivity is 45%. So you can lose that image of the heart during Valsalva strains. When the probe is on the chest itself and the patient provides a Valsalva, it may be difficult to maintain contact and stay in that same area to visualize that PFO. Another exam performed to diagnose PFO is a TEE. This is where the patient lies on their side. The doctor places the TEE probe into the mouth and down the esophagus. This provides excellent visualization of the heart and its structures. The tunnel measures the shunt itself. It has a high specificity. There are some cons, however. The procedure is invasive. The patient is sedated. Valsalva cannot be performed. A lot of these PFOs are not an opening, but a flap. So that Valsalva, when you take your breath in and hold and bear down, that PFO will open, and that is when most of the PFOs are identified. So the reason that you cannot perform an adequate Valsalva during this exam is significant. As we said, TCD is a highly sensitive method, can be easily performed. This is a picture showing the manual head frame. So you can put a manual head frame on with small probes on either side to stay in place on the middle cerebral arteries bilaterally during your agitated saline injection. What we can do with TCD bubble studies is we can grade them. So this is huge. We can say how big potentially this PFO is to help guide treatment options. And this is the detailed grading ability that we have with TCD. So we can count how many bubbles are crossing over from the right to the left atrium. There are two different ways to count these bubbles. We have the Spencer grading system here. We have grade 1 to 5, 5 of course being the most severe. If there are 3 waveforms completely whited out with bubbles, this is your grade 5. And then we have the ICE criteria. And then with the ICE criteria, we are only looking at the spectrogram. We will count the bubbles within the spectrogram only, and we have grade 2, 3, and 4. In the Spencer, we're looking at the bubbles in the M mode. So we'll count all of these bubbles within the M mode itself to provide a Spencer grade shunt. This is just a brief overview showing the clinical trial results on shunt identification. As we mentioned, 43% of our cryptogenic stroke patients will have a PFO, and this is evidence showing that TTE missed these and TCD found them. So here are your images on your TTE that did not identify a PFO and how the TCD did find them. Look at all of these bubbles that crossed over. These PFOs were identified on TCD. Okay, let's get into the supplies that you will need. You will need a 3-way stopcock. You will need some saline. The bacteriostatic saline is preferred, and you will need 4 10cc syringes. The workflow for a TCD bubble study. So we know that PFO is not necessarily a hole, but a flap, and it's a connection between the two atriums. You will need your agitated saline with blood drawback, half cc blood drawback, injected into the antecubital fossa, and we will monitor live for these bubbles to show up on our TCD. Now these bubbles look as bright white lines. Commonly, you will see them within the waveform and within the M mode. They will be at a slight slant through that M mode because they're traveling through time. There'll be different things to watch for. We'll reveal a bit more into this presentation, but this is just artifact here. There are no bubbles in this picture below. So what is the significance of the Valsalva? As we mentioned, the PFO may not be an opening. It may be a flap. And in this case, that is why they are missed commonly on TTE. So when it is a flap, the Valsalva will open up that flap. And what we will need to do to ensure that Valsalva is performed properly, we will watch a decrease in the mean velocity, or we will select delta on the machine to see the percent decrease in that mean velocity during Valsalva. So that mean velocity should decrease 20 to 25% as that patient is performing the Valsalva. And then once they release, that mean velocity should go higher on the screen. So we will make sure that our scale is high enough to capture that waveform as it increases with the Valsalva release. As we mentioned, we are going to make sure our scale is increased to obtain a waveform that has a higher mean velocity once the Valsalva is released. In addition to that, we'll make sure that our gain is not overly bright. We want to see these bubbles. Those bubbles will be bright, but we do want to make sure that our machine doesn't have the gain too high so that we are able to identify all of the bubbles that are crossing through. So we will select bubble on the protocol. We will make sure that our gain is lowered and our scale is higher. Tips for performing the injection. The resting bubble injection, of course, there's not going to be a Valsalva. After the nurse has agitated the solution at least 10 times vigorously, say to the nurse, start injecting. Immediately press the rest button on your TCD machine. The NovaGuide View or the NovaGuide 2 will record 1 minute during that rest injection. And then we'll do a strain bubble injection for that second injection. After the nurse agitates that solution 10 times again, of course, that half cc blood drawback, say to the nurse, start injecting, immediately press Valsalva button on the right side of the NG2 screen and have that patient perform that Valsalva. They will hold their breath for 10 seconds and release, and we will watch for that full minute as the machine records. Now you can provide a calibrated or a non-calibrated Valsalva strain, however you decide. If you do a calibrated Valsalva strain, you will attach oxygen tubing to a manometer. You'll have the patient put the oxygen tubing in their mouth with their free hand if they're able, and then ask the patient to take a deep breath and blow into the tubing. You'll have them hold their breath steady at 40, and while you count audibly to 10. You'll make sure you count audibly to 10 so that patient knows when they can release their breath. If you do not use a calibrated strain, you can watch that mean velocity. As we said, it will be decreased during Valsalva, and then the mean velocity will increase once that Valsalva is released to know that a proper Valsalva was performed. There are a few potential scenarios to be aware of. If the patient cannot perform a Valsalva, still perform the resting portion of the exam and attempt the Valsalva strain by pushing over the liver for a count of 10. The pressure over the liver may compress the IVC, simulating a strain. If there are no temporal windows found, you can still perform the exam. These bubbles are highly echogenic, so with the transducers on the side of the head, even though you are not seeing a signal, once those bubbles are pushed, you can see the bubbles come through if there is a PFO present. This is something that I didn't believe until I saw firsthand. It does work. You cannot confirm a negative PFO, but you can confirm a positive if those bubbles are crossing over and you're able to see them even when there's no waveform on the screen prior to your injection. If you have an unsuccessful strain maneuver, if the patient practiced the strain maneuver correctly but was unsuccessful during the live exam, repeat a practice session and then repeat another strain injection. Now, if the IV site is central or at the wrist, a central IV line will affect the timing of the strain maneuver. Have the patient perform 10 seconds of strain. At the end of the strain, immediately ask the nurse to inject. A central IV line is closer to the heart, and those microbubbles will reach the right atrium at a faster pace. As such, the strain needs to start sooner. A wrist IV line will affect the timing of the strain also. So ask the nurse to perform the injection and then ask the patient to perform the strain immediately after completion of a full injection. That wrist IV line is farther away from the heart, and those microbubbles will reach the atrium at a slower pace. So as such, the strain needs to start a bit later. What will those bubbles look like on TCD? This is a big portion of the exam. So this will show you exactly what you will want to look for. They will have their unique characteristics on the screen, but they will have a unique sound. They have a popping, chirping, snapping type of sound. And then as we mentioned, since it's traveling through time, it's going to be at a slight slant through that M mode. You're going to see a higher concentration of white within the spectrogram, and you're going to see those lines through that M mode, and you can see there how it's slanted it is. And you will identify that popping, chirping, snapping noise on each of these exams. If you do have situations where there is a bruit, you will see that within every waveform as you see here. And then of course you'll always have artifacts. TCD is sensitive, so it'll pick up when patients are talking or moving, and you will see lines on the outside, and they're usually straight lines, and you will see these on the outside of the waveform itself. They're not within the waveform. So this is artifact, these are bruits, and these are bubbles. Here is a TCD bubble study being performed. This is a grade 5 shunt, and you'll watch as the patient releases Valsalva is when the bubbles will be pushed through. Mean velocity is decreasing with Valsalva. Valsalva is released. Here is an example of positive TCD bubble exams. We have grade 2 here, grade 4, and grade 5. No need to count our grade 5s. You can see 3 solid waveforms that are white and a whole curtain of white. This is confirming a grade 5 Spencer shunt. So you can see the difference between what these grades will look like. How to perform a TCD bubble exam on your NG2. You will first log in, and then you will have this screen. You will need to select your new patient if you are manually entering in that patient's information, search patient if you have performed an exam on that patient prior, and work list if you have set up that modality to connect to your EMR. On your system, you have the ability to perform a complete exam, monitoring, bubble, emboli, VMR, breath holding index, and morphology. We are performing a bubble exam. This is what you will select. This will be your next screen. You will select manual TCD if you are doing handheld or using the manual head frame. If you're using the robotic system, you will select your probe pod check. This is the screen you will see with your manual system with the manual headset. You have your MCAs bilaterally and your rest and Valsalva options here on the right. If you continue on to the robotic system, you will place the stickers on the side of the head, at the tragus of the ear, and the corner of the eye. You will place gel between those two stickers. You will align your head cradle symmetrically to the patient's shoulders and down the nose and the chest. First, you will see this screen. Then you will advance the probe pods to the patient's skin surface, and those will light up in green on both sides. You will select next, and you will see the video identify our sticker placement so that we can proceed to the next step. This is the next screen that you will see. You will see your MCAs bilaterally. The top portion you will see only if you were doing your manual head frame. The bottom portion is your robotic controls. You have rest and Valsalva injections over here. You will select for each session, and that will record 1 minute of the exam. This is showing a positive bubble cell. Post-processing, you will have, once you select exit the exam, this is the screen you will see. You will have your events and your snapshots. You will select the ones that you want to include in your exam. You can select the camera buttons up top. That'll include all of them. You can toggle back and forth between your right and your left, and you can press your play button to count these bubbles. You will identify the number in your box right here. So say you did see 2 bubbles here, you would put 2 here, and you would go to your other side and you'd do the same. You do have to include snapshots on your exam. So you will go to the snapshot side and you will select the snapshots to be included in your exam. And then you will select next. If you did need to review anything, you could do the exam replay, and that entire exam is recorded, and you can take any additional pictures that you have missed. The next screen, you will put in your reporting verbiage. So here you'll say a TCD bubble exam was performed with a 2 MHz probe. The bilateral MCAs were monitored with agitated saline injection at the anacubital IV during rest and while an adequate Valsalva was performed. The number of bubbles are reflected in the boxes above. And since we reviewed the exam and put in the number of bubbles, this shunt grade is automatically acquired for us. So we have our review of how many bubbles will determine what grade, Spencer's shunt grade, and then the machine will provide us the grade that we need. There are a few different treatment options for our PFO patients. You can do an antiplatelet treatment, surgical option for Spencer grade 3 to 5. That is a significant shunt. A common treatment option is closure. So PFO closure is a same-day outpatient procedure performed under general anesthesia or conscious sedation in a heart cath laboratory. So the catheter-based procedure involves making a very small skin incision guided by fluoroscopy and intracardiac echocardiography, typically in the right growing area, and inserted a catheter to guide to the PFO occluder through blood vessels to close that PFO in the patient's heart. So you can see that hole here. You can see the occluder on both sides, and they will close that together to treat our PFO patients. And here's the data showing the efficiency of our PFO closure devices. You can see the different studies performed and how they are showing that these PFO closures will work. This is increasing the need for an accurate diagnosis so that we can provide this proper treatment. The recent studies are driving changes in the guidelines for stroke management. Moving on to our NovaGuide View. If you do have our NovaGuide View, this will provide an excellent way to organize your reporting system. You have the ability to live stream on your phone through the app on your home computer. You can watch these exams. You can pull these reports up anywhere. You can provide your impression and sign off on these reports as well. So what we'll do, once we log in, you'll have this screen. You will view your exams. After you select View Exams, you will see this screen and you'll be able to select any of these studies that you want to review. This is walking us through our NovaGuide View screen. You will have your patient's information up top here. You will review the images on the bottom to make sure that the bubbles that were identified are accurate. And then you can put in your reporting verbiage. Your technique description will be included here with that transcranial Doppler exam was performed using the NovaGuide robotic system. This can be adjusted accordingly to your facility. This will entail the transtemporal windows were insunated to monitor the intracranial blood flow for microbubble emboli during bacteriostatic saline injections. Notes are always helpful for the sonographer to enter if there are any limitations or anything that needs to be noted. And then your conclusions, you can always put in there what your Spencer shunt grade was on each of your patients.
Hi, I'm Michelle Hamilton Kimbrough. Come in with a machine on wheels and it rolled around to the side of my bed. It was comfortable. I wasn't in any pain. I had to breathe when she asked and hold my breath in, and it was able to detect the PFO, which was the hole in my heart. So after I met my doctor, Yanapati, we went over the PFO to have done, and I was nervous, but after hearing how it was gonna happen and the whole procedure, I felt okay, and I was like, okay, let's do it. I am so grateful, and I appreciate, like I said, all the doctors and the technology that was used. I'm back to living life again. I'm back at work with my preschoolers, dancing, running around. I'm back living life with my husband. We enjoy going to the Padre games, and I don't think I would be here without all of the help, the tests, and the doctors. So I'm so grateful for that.
So there are some tips and tricks of TCD. If you're doing handheld TCD, make sure you always have a good connection to the patient's skin surface. Use your pinky as an anchor to keep that probe in place. If that patient's head moves, your hand moves along with them. Never settle for that first waveform if you're checking for high mean velocities. Know your window locations, your temporal window locations for probe placement. When there is a difficult temporal window, increasing the power and sample volume can help when all else fails. When performing emboli monitorings on PCAs for vertebral and basilar source, ensure that a fetal origin PCA is not present. Always look at your patient history. Obtain a good patient history prior to TCD exam. Review your CTAs, MRAs, and angios. If performing a PFO study or emboli monitoring study, please look to see if that patient had an echo within the prior 24 hours. There are contrast solutions called Lumason and Divinity that can appear as bubbles on our TCD, and this can interfere with our diagnosis. Correlate your TCD findings with CTAs and angios. Ensure your diagnostic criteria is accurate. Adjust your diagnostic criteria accordingly. Keep your hand slow and steady for maintaining contact to the patient's head, and always watch for those high mean velocities when checking for stenosis or vasospasm. That is all we have for today. Thank you for your time and attention.